Talking about addiction is very important because substance dependence is very important, because that actually becomes important for you guys when you are managing patients that gets admitted. So although it's a small percentage of patients, we have to know how to deal with physical addiction to alcohol and how to manage withdrawal. So it's important that we start screening patients better for alcohol misuse disorders. There's a couple of screening tools that we particularly want to use. So everybody's aware of the CAGE. I'm going to show you the tweak today, which is a slightly upgraded CAGE. And then if your CAGE is positive, ideally you want to use actually your audit to do a bit more of an in-depth examination. It's also helpful to remember that some people might be withdrawing unplanned. So maybe they suddenly didn't have access to alcohol, or maybe they end up with a medical condition in your ward, and suddenly you're not even aware that they're drinking that much alcohol, and they might end up developing withdrawal in your ward as they don't have access. So this is what the tweak questionnaire looks like. The tweak stands for tolerance, worry about drinking, eye opener, amnesia, and cut down on drinking. You can see it's similar to the CAGE. It's got a higher specificity and sensitivity. Some of the questions are the same, but the two that's different is tolerance. So you're asking how many drinks does it take before you begin to feel the first effects of alcohol? And the other one is amnesia. Are there times when you drink and afterwards you can't remember what you said or did? So that just as another way of screening for whether there might be an issue. The other one is the alcohol use disorders identification test. There's a self-report version that works quite nicely. You have to show the patient in terms of what you mean by a unit of drink. And then there's just 10 questions that you go through, and they're very similar to that DSM criteria to help start identifying who do we think has got hazardous or harmful drinking. When you have somebody that you're admitting, for example, who has had has got heavy drinking as an issue, there's a whole lot of physical complications you just need to go and look out for. And some things that are particularly relevant, for example, you've got your alcohol cardiomyopathies. You can actually get lung pathology secondary to aspiration that might even have happened before the patient came to hospital. You want to look out for possible head injuries. You want to make sure you think about your vitamins and your thiamines, and always useful to just check with your urine toxicology if there are any other substances in the mix. So on your bloods, you have to go quite widely because so many systems can be influenced. And just remember to do your HIV and TB screening. So alcohol withdrawal is got to do, so alcohol is a depressant. So what alcohol basically does is it depresses large parts of the body, of the brain, especially this inhibitory part of the brain. So when one withdraws, you end up having the central nervous system hyperactivity when you suddenly reduce your alcohol. And there's different types of symptoms. So there's autonomic symptoms, and your seizures are part of that autonomic picture. There's all your gastrointestinal stuff. And then there can be a whole range of cognitive and perceptual disturbances that might happen. So our substance-induced psychosis is that we sometimes see as well. What's helpful to remember is that some things like some of your insomnia, your tremor and stuff like that can start already within 6 to 12 hours. But full-on DTs, which we'll talk about in a minute, can take a good 2 to 3 days to develop. So you might have somebody who has stopped drinking a day or so ago. They might present with another medical condition, and they might develop DTs in your ward after a day of admission, if you're in a district hospital setting, for example. So very important, if you have somebody who's come in and is known with heavy drinking and you've classified them, okay, they might have alcohol dependence, you want to know what is the risk of this patient actually developing delirium tremens. So there's a very useful tool called the Clinical Institute Withdrawal Assessment for Alcohol Scale. There's a guideline for a South African guideline actually on managing substance withdrawal. And it's 10 questions that you work through. And if there's more than 15, then there's an increased risk of DTs, and you want to keep a really close eye on those patients. You can also use this scale when somebody's going withdrawal to sort of roughly keep an eye on what their withdrawal symptoms are like and tailor your treatment accordingly. So the thing you might need to decide, so sometimes you might also come a patient in, he's extremely drunk, might have other medical stuff going on, or the patients might come in, they are requesting for whatever reason that this patient needs to be withdrawn from alcohol, and you decide that you're going to do a detox. Again, I'm thinking of you guys in the district hospital levels. And you need to decide who are you going to admit for an inpatient detox or who you're going to do an outpatient detox. There's actually very few patients that's going to qualify for an outpatient detox, because outpatient detox requires a very sorted caregiver at home with a written plan that can give the Valium, the diazepam, is able to access hospital services immediately if something goes wrong, et cetera, et cetera. And we don't usually have that level of support in our communities. But definitely if you've got patients who's had convulsions in the past, who's had DTs in the past, who's got psychosis in the past because of their alcohol withdrawal, any patient who's got any suicidal ideation, majorly medically ill, elderly and pregnantly patients, or if they're also using a whole lot of other opiates, patients like that, you're rather going to detox in your hospital setting. When you admit them, you obviously want to monitor their vital sign. A big thing to look for is that electrolyte and nutritional deficiencies. Always give thiamine. We'll talk about that again in a minute. And in the old days, they used to give magnesium routinely, but you only need to give magnesium if the magnesium is actually low. So this is the guideline, the South African Addiction Medicine Society guidelines for the pharmacological management of alcohol use disorder. They've got quite interesting, complex variety of detox regimens that you can use depending on your setting and what drugs you've got available. I'm just going to show you what's in the EML. So the EML gives a very simplified way of doing withdrawal or managing withdrawal. And of course, the only substance that we use for withdrawal in our setting is the benzos. So you can either use your short acting or your long acting. Your short acting is not as fun for the patient, because every time it starts wearing off, the withdrawal symptoms come back. So if you do use the short actings, but the short actings is slightly safer in terms of respiratory suppression, for example, but you've got to be able to put them on a fixed dose regimen and be able to give that quite regularly, or the patient's not going to be very happy. And it's a bit safer if you've got patients, for example, with liver dysfunction who's not properly excreting those opiates, as otherwise it's going to build up in the system. But you can also use your longer acting benzos. So diazepam is slightly longer acting, but then particularly your clonazepam was much longer acting. And that gives a much smoother withdrawal and less breakthrough withdrawal features, got better seizure control and effectiveness in DTs. But there's this risk of accumulation. So you're going to have to look at your patient to decide, am I going to go for the lorazepam version or am I going to go for the diazepam version? In the EML, they're using the diazepam as a way to do your withdrawal because it has that slightly longer acting. And there's a regimen, you can look it up in the EML if you're in that scenario in terms of how you can give it. And you can see it's over quite a short amount of days. So the physical withdrawal doesn't take a very long period of time. And of course, very important to add in that 300 milligrams of thiamine. So a lot of our alcoholic patients are not eating properly, biting down a lot of vitamins and beer. Thiamine absorption actually gets affected by the alcohol. And so a lot of them gets thiamine deficient. And of course, the risk is of Wernicke encephalopathy. So if we think about Wernicke, everybody knows the classic triad of Wernicke encephalopathy. So that is particularly caused by thiamine deficiency due to alcohol. And there's usually a triad. Well, not usually. The triad is only actually seen in 16% of patients, but the triad is what we all get taught. So the patient's confused, they've got ophthalmoplegia or nystagmus, and they've got ataxia or gait problems, sort of the classic, they look like they're drunk, but they're not actually having any alcohol. So there's been a proposal of rather using what they call an operational criteria. So if you have that history of the dietary deficiency or the alcohol use, plus oculomotor or cerebellar, or even just mild memory impairment. And so actually the guidelines, the South African guidelines actually talks about a presumptive diagnosis of anybody who's going alcohol detoxification and is any one of those. So if they either have ataxia or hypothermia or hypertension or ophthalmoplegia, or even just a slight change in consciousness, then you want to get them onto high-dose thiamine. And I don't know if we've got IV thiamine. We do have. So that's when your IV thiamine will become very important. And in the EML, there are details in terms of the dosing. So delirium tremens, so I was looking up pictures for delirium tremens. You know, there's a beer called delirium tremens. I mean, really, but anyway. So delirium tremens is not that common. So it's about 4 to 15% of patients going through withdrawal. Some patients will just get the seizures. About 4 to 6% of patients will actually fit. And usually it happens between 2 to 3 days after they've stopped the alcohol. So it can catch you out. The patient might come in with fits and might not be smelling of alcohol or looking like he's been drinking, and you have to get a good history to find out maybe for some reason that he no longer had access to alcohol or whatever. The symptoms peak around 5 days, and it's got a mortality. So this is when people drink themselves to death. It's literally to do with the DTs. So it includes a whole lot of cognitive things. So your hallucinations, your delusions, your disorientation. So when we're thinking about substance use disorder, you need to make sure this is not part of a withdrawal picture and possibly DTs. But the worrying things is when they start developing seizures, and they can have tachycardia and hypertension as some of the physical symptoms of DTs. So you need to be able to identify predictors for who might be getting a DT. So if somebody is at previous withdrawal seizures, they've got a very high risk of developing that whole DT picture. Anybody who's gone through previous detoxes, so every time you detox, they call it the kindling effect. There's a higher chance that next time you're actually going to get full on DTs and actually going to fit. And obviously, if you've had DTs before, there's a high risk that you're going to have DTs now. But there's also things that can give you a clue, such as low platelets and potassium. But remember, we talked about that scoring system. So a scoring system of over 15 on that score, there's also a high risk of DTs, and you're going to watch those patients very, very closely. So when you are admitting somebody with DTs, very important your cardiac monitoring and oximetry, because we're going to give them high doses of benzos. These patients should be in an ICU setting so they can provide high care, 24 around the clock nursing care. You certainly don't want to be doing this, for example, in an A&E setting or even in a normal ward. Overhydration is actually an issue. So sometimes we think, oh, the alcohol makes you dry, but remember they haven't drunk for a few days. So you've got to watch out that you not overhydrate them. Check what's happening with their electrolytes and that nutritional support, specifically your thiamine. So the EML, again, I'm not going to go through these in detail because you'll look it up if you're in that scenario. The principle is basically you're going to be giving them diazepam. And remember, a lot of these patients are also fitting or about to fit, and you're going to be watching them very closely while you do that. This is IV diazepam is your first choice for somebody who's fitting with DTs. If you don't have access to IV diazepam, we don't like using IM diazepam. And then you're going to look at either using clonazepam or lorazepam IM. And you're going to be basically giving it every 30 to 60 minutes until your patient is sedated. Once you've stabilized that patient initially, the idea is to keep the patient slightly drugged throughout their admission. So they're actually going to be on regular oral diazepam, and you're going to give enough to keep them mildly sleepy throughout the time to sort of keep this very hyper activity at bay in terms of preventing a future fit. So there's a couple of cautions, and this is straight from the EML. So of course, just remember that IV diazepam might make them stop breathing. So don't do in a scenario where you can't actually bag your patient. But also because you're giving them benzos, you might miss Wernicke's and various other things because you are actually sedating them. And then there's a little bit of tips in the EML in terms of lorazepam and clonazepam use. Because you're giving things IM, you less, once it's in the system, it's in the system. Lorazepam takes longer to start working, but then works for much longer. So you need to know that in terms of how you monitor your patients. But the clonazepam is quite good. It's got a very long half-life. So you've got to watch out for that risk of accumulation in, for example, elderly patients or liver patients. If you're giving patients any glucose-containing fluids, then you want to give that thiamine. I would give thiamine routinely anyway, and look out for your Wernicke's if you actually want to introduce some IV thiamine. If you've got patients with DTs with psychosis or restlessness, so this might be a patient who comes in who's now in A&E, who's all over the place. There's a couple of things to just remember. So generally watch out a little bit with haloperidol because of QTC prolongation. So the idea is actually, if you've got somebody who's got alcohol as a cause for their psychosis, rather use your benzos than using your haloperidols. You can use haloperidols once they're stabilized for that, if they've got hallucinations, frank hallucinations, but you're going to watch that dose. So you don't want to give more than 5 milligrams in a day, and you want to start slow and build up. And very important, so in the new guidelines, there's a big emphasis on olanzapine, which we don't yet have, but it will come, as an IMI for psychotic patients, but you don't want to do that if the psychosis is due to alcohol withdrawal. So olanzapine together with benzos, together with alcohol is a very huge risk of respiratory depression. And so rather use haloperidol and benzos in these patients. I've got just one slide on some of the medication that one can use for relapse prevention. This is usually used by substance abuse programs because on their own, they don't do very much, but they're useful for a patient who's motivated. And the famous one, of course, is antabuse or disulfiram. So the idea with this is that if you've got disulfiram in your system and you drink, you're going to get really, really sick. And you can only do this with full cooperation of the patient. So the patient goes, this is how I want to control my dragon. My dragon has got a desperate need to drink because that's how I cope. And one of the ways I want to keep my dragon to sort of use a deterrent is by, if I know that I drink, I'm going to feel really, really hoor. So you can't have somebody slipping it into their tea, for example, not good. Because some of the side effects can be quite dramatic. Got to monitor your patient's liver functions. And the idea is they must have had at least 12 to 24 hours of no alcohol in the system before you start it. And if they decide they're going to start drinking again, or they want to go drink at a wedding or something, they've got to stop it 7 days before they take alcohol again. So there's a lot of counseling that happens. There are some drugs not available to us in the private sector. So acamprosate is registered in South Africa. That actually reduces craving a little bit. And again, it only works within the larger package and only really works for people who actually had dependence. It's not going to help for somebody who's just got using it as a coping mechanism. Naltrexone, there's actually some very good evidence, but that's for off-label use in South Africa. It's not yet available in South Africa as an official use, and particularly also for things like cravings and reducing cravings. So great. So let's